Good morning. I just wanted, before I start, I cannot continue without thanking Jill and Rabbi Aaron Grinstein for the lovely dinner last night, and thank you for the invitation. And before I start, I have a little story that I'd like to share. I'm diverting a little bit from the topic, and this is an account. This is an account from one of your famous historians, Josephus, who made an account of one of the few, or probably the only contact that Alexander the Great made with the Jewish people at the time. And it was a time when he just invaded Persia, and he was on his way back, and I think he made a detour to come and visit the temple. And at the time, there was a high priest by the name of Jadua, or Jadua, I don't know the pronunciation. He saw a vision, a message from God, that he was wearing a purple robe and he had a gold placard with the inscriptions of God written on his forehead. And when Alexander the Great made it into the city on his way to the temple, they all came to greet him. And the first thing that Alexander the Great did was, in honor of God, he got onto his knees and knelt and bowed to Jadua. And you can imagine when he stood up what his generals were saying, and how can you be doing such a thing? And Alexander the Great responded by saying to him, "It's not. I'm buying to the God of the man who was honored, his high priesthood, not the man himself." And so he paid reverence to God himself. And that's when he got up and he went back into the temple, and they performed a sacrifice to God according to to the high priest's direction. And in there, Joseph showed him a passage from the book of Daniel, where it said that one day some Greek from a Greek empire would be the one to conquer the Persian Empire. And obviously Alexander the Great thought this was his, alluding to himself, because he himself saw a vision while he was in Macedonia, thinking about conquering Persia, where he saw this image of this high priest in his dreams, who was then telling him to rush to Persia, and that he would be protected by God. So that is a little story about the old Greeks. But for us to get back to what we're about, I'd just like to give you a little bit of where we come from and what we're about. And Robbie has alluded to our difficulties and our resource-restricted, constricted environment. And one can understand where we've come from and where we're going to. So around about the 1890s, already general surgery was performed in Johannesburg. And by 1920, the first professor of surgery was appointed at the Johannesburg Hospital, and he was from the Glasgow Royal Infirmary. In 1948, the Baragwanath Hospital opened its doors, and as you know, later in the late 70s, I think in the early 80s, already was performing open heart surgery as well. And you might recognize some of the names. We've had a few Nobelists from Wits, and amongst others, a famous Philip Tobias, who was a world-renowned scientist on human evolution and study of fossils. Now, the Johannesburg Hospital has a capacity of about 1,100 beds and currently running at 990 beds. We have two cardiac theatres, one thoracic theatre, down from three cardiacs and two thoracics. Our ward beds have been reduced to 26 beds from 48 at the initial at this hospital, plus another 40 at a peripheral outreach hospital. Our ICU beds have just recently been increased to 8 beds from 5, with 12 high care beds, and this includes the adult and pediatric cardiac surgery and thoracic surgery. We have around 14 private units in Johannesburg, in Gauteng, performing cardiac surgery. And these are some of the numbers, excluding the doctor's fees, it would cost you to do a private case. Versus it's almost half the price to do a private case in the state hospital. I don't have the exact numbers for a state case. And we serve a population of about 12 to 14 million. The first cardiothoracic professor was appointed in 1974, and we have a Wits complex of hospitals, which is our referral base. The Charlotte Maxeke now Academic Hospital, the Helen Joseph, and the Baragwanath Hospital. So in the 1980s, we were performing around 1,500 cases, cardiac cases per annum, and around 800 thoracic cases. And that's down to about 450, between 400 and 450 cardiac and 600 thoracic cases. So what I'd like to show you is really a little glimpse of what we're doing in terms of an audit in a really resource-restricted and administratively restricted environment. And you've got to understand that some of our patients, our limitations really is, for long-term follow-up is very difficult due to our patient population and non-compliance, or poor compliance. So some of the pre-op characteristics include most of our patients are African. We have a relatively young population, around 45 years old, and most of our patients were males. You'll see there the incidence of diabetes in our patients. This population was around 6%, which is a bit lower than the national average, which is 8%. We had about 4% of the patients had Marfan's, and low cardiac output syndrome and cardiac tamponade pre-op were around 4.5% to 5%. So most of our, at least about 46% of the cases were really performed on the same day or the day after. Cross-clamp times were around 63 minutes. Deep hypothermic circulatory rates, mean times of about 34 minutes. About 7 cases, 2% of the cases required an intra-aortic balloon pump, and another 2.5% or so required ECMO post-op. There were 4 cases which really essentially were abandoned, 2 due to cardiac arrest while transferring into theatre with multiple comorbidities, and 2 due to clamps that were displaced because of rupture of the aorta intra-op. Our mortality was around about 15%, and the intra-op death rate was about 3%. ICU stay was about 4.5 days, and hospital stay around 2 weeks. Our global stroke rate was about 8.4%, and low cardiac output state post-op was about 6%. Bleeding post-op was around 10%, and deep sternal infection was around 2.6%, with dialysis around 3%, and the respiratory complications around 23%. So as you can see, you have most of the cases, including aortic dissection, thoracic aneurysms, trauma to the thoracic aorta, were all really essentially done on the same day or the following day. Redo surgery on the thoracic aorta was mostly done after 24 hours, largely because we needed to optimize possibly some of the patients. And the thoracoabdominal aneurysms, the reason of most of the cases were emergencies, they were all mostly bleeding thoracic aneurysms. I apologize for some of these slides. It's obviously a gremlin. But anyway, one can see to the left there was a little cluster of morbidity and mortality during the first few years of this, between 95 and 98, 2000. And that was probably mostly surgeon specific at the time. Again, the same thing with cause of death. Most strokes and hospital mortality, as expected, would be done because of emergencies and salvage operations, as well as the deaths. Patients that had most dialysis were almost equally distributed between emergencies and electives, and I guess the ones that had elective surgery were the ones that we were trying to possibly optimize that were in pre-renal dysfunction and had other comorbidities. This was also a period before 2000 when we used to run our own intensive care unit, and after that it was taken over by the intensivists, so we really had no control of our post-op patients in one way, and one can see how the mortality has jumped. The type of procedures, most procedures, around 68-70% were acute dissections, and mostly type A dissections. The site of entry, most of them were in the ascending aorta as expected, and followed by the aortic root and arch. The procedure type, a good number were around 60% were interposition grafts and around 30% interposition grafts with aortic valve repair in the form of aortic valve resuspension, and some other concomitant procedures included in the case of aneurysms were coronary artery bypass grafting, mitral repair, tricuspid annuloplasties. The modality of cerebral protection before 2002, it was predominantly, I apologize for the slide, it must have been due to, I think we just changed from Apple to the PowerPoint presentation. But anyway, it was predominantly retrograde cerebral perfusion and deep hypothermic circulatory arrest with a mortality of around 22, anyway, the mortality is around 22.3%. I don't know what's happened to that. The mortality is around 22%, sorry, and 35% of the cases were retrograde cerebral perfusion. After 2002, we predominantly used low flow with deep hypothermia, with or without antegrade cerebral perfusion. Those were the majority of the cases, and the mortality was a little bit lower at 15%. Now, the pathology, the majority in aortic dissections was a mucoid vasculopathy or vasculitis, followed by atherosclerotic disease, and some were marfanoid. In thoracic aneurysms, again, it was a mucoid type of vasculopathy or degeneration, and followed by some type of aortitis. Okay.
Finish.
Can I finish off quickly?
Conclusions.
All right. I'd just like to, I was going to show you a couple of cases here. This is a case with a 60-year-old male with comorbid disease, extensive, morbidly obese, severe triple vessel disease, and a previous laparotomy, and a calcified coarctation. And we performed a triple vessel CABG and an extra anatomical bypass from the ascending aorta to the aorta by fem subcutaneously. So one can see the two branches of the graft. Another case was a stent, a 30-year-old male who came in with a post-motor vehicle accident with a contained rupture of the aorta. The vascular surgeons got to him quite early, as you can see, and implanted a stent that appeared too big and almost kinking the proximal descending aorta. So he came in about a week later, almost in a shock state, and he was taken for open repair and removal of stent.
We have to conclude.
Okay. To conclude, I just wanted to say that our burden of disease is quite high, and I'm sure we're missing a lot due to the poor income population. The early outcome is okay despite the difficulties. And before I finish off, on Sunday I went to Masada and the Dead Sea, and I'm aware of the situation that this is probably the most vulnerable spot on the planet. But I thought I was having a holy moment when I saw goats on trees and a flash flood in the desert. Thank you.